A very good evening to all the postgraduates who have joined us today. We are excited to have this educative session here. Our presenter today is Dr. Ashwin from CNBC Delhi, and our examiners are Professor Velmurugan, who's the HOD of the Institute of Child Health, Madras Medical College, and Professor Prabodh Goel from AIIMS Delhi. Over to you, Dr. Ashwin. You can start your presentation.
Uh, Good evening, sir. Good evening, everybody. I am Dr. Ashwin Adamdu from Chachaneru Bal Chikitsalaya, Delhi. Today, I will be presenting a long case on a lump in upper abdomen in an infant. Uh, a 3-month-old female named Kaniksha, who is a resident of Muzaffarnagar, Hindu by religion, came to OPD with her mother, who is reliable informant, with the chief complaints of lump in abdomen noticed on the day 8th of life. This was the only complaint she came with to the OPD. And as per mother, patient born at term via normal vaginal delivery without any events during delivery. Her antenatal scans were within normal limits, and postnatally, patient did not had any hospital or NICU stay and was feeding well. But at day 8 of life, parents noticed a lump at mid upper part of the abdomen, which was of size of a lemon, which was insidious in onset and gradually progressed over 3 months to size of approximately 10 by 10 centimeter, and was occupying whole of the upper abdomen. There was no any other associated symptoms other than the lump in the presentation as per mother. There was no history of any decreased feed acceptance or feed intolerance in the patient. No history of fever, no history of vomiting, no history of respiratory distress or breathing difficulties, no history of any excessive crying, no history of jaundice, hematemesis, no history of any patches or reddish patches or lesion in the body, no history of failure to thrive, no history of trauma, or no history of lethargy or constipation in this patient. Coming to the family history.
Can I interrupt you, Dr. Ashwin?
Yes, sure, sir.
One thing is, see, can you come couple of slides back? One more slide. So you talk of a lump which was there since day 8 of life, and the child is now 3 months of age. You have
Yes,
told
sir.
us about the lump at day 8 when it was first noticed by the mother.
Yes, sir.
In it, you said it's in the upper mid part of the abdomen. I think we rather would classify it right upper quadrant, right lower quadrant, left upper, left lower, which is a standard way of classifying when we are taking the parental description, number one.
Yes, sir.
Number two, if you look at description of this lump, there are so many points that you have described here in the history. But anyway, even if we are focused, you have missed one very important aspect, that how has the lump grown from 8th day of life to 3 months. So whenever you have a case like this, you have two time frames. One time frame is when it was first noticed. You describe at that point, and then you have to tell us the evolution of the lump from 8 days to 3 months.
Right, sir.
So can we go on this evolution part?
Sir, the lump was incidence onset as per mother, and it gradually progressed over 3 months of duration.
Again, I'm sorry, I'm interrupting. Incidence and onset, you don't know that. No? It was noticed suddenly at day 8 of life.
Yes,
so
sir.
You cannot say it was incident. It was a random finding. You can say it
Right,
was
sir.
noticed
Accidental
accidentally or incidentally.
Yes, sir.
We don't know the onset, right?
Okay, sir.
And then what happened after day 8? Has it been growing in size?
Yes, sir. It was initially of size approximately of 2 by 2 centimeter. That is the size of a lemon. Then it progressed gradually.
Again, I'll interrupt you. Sorry. See, either say 2 by 2 or say lemon. I'm sorry, I'm interrupting again and again. The basic concept is, I'll give you. Well, sir, can I continue?
Yeah, please.
So I'll tell you.
I'm listening and learning.
It's like a race. The history and the examination part, the good you are at it. And see, normally kya hota hai? Long case mein, they usually examiners have something in mind. Will give 40 minutes. Now, if in those 40 minutes you spend up 25 minutes with a very good history, very detailed one, and examination, which is non-controversial, so already spent 25 minutes. And if you've crossed it without interruption, so use only one classification. Either say it was 2 into 2 centimeter size, or it was lemon sized.
Okay,
right?
so it was size of a lemon only.
Okay, it was lemon size at the day 8, incidentally noticed. Then what happened?
Then it gradually progressed and increase in size.
Gradually progress and increase. Progressive, gradually increasing in size. Okay, then what?
And then it became of size of 10 by 10 centimeter when patient came to us.
Okay, so it's almost become 5 times the size.
Yes, almost, sir.
Okay, what else during this progress?
And the as it was arising from the mid upper part of the abdomen, and at the presentation it was occupying the whole of the upper abdomen as per the history
Initially,
given
it
by
was,
me.
you want to say mid upper part or you want to say the right upper quadrant? Which is more appropriate here?
Sir, actually in this patient the mid upper part was more involved.
Okay, so it was in the midline basically.
Midline, yes, the epigastric leg.
Okay, and now it is involving the whole abdomen.
Right, sir. Yes.
Okay, and you gave a long list of negative history. Can we come to that? Next slide, I think.
Yes, sir.
So all these histories were negative at 8 days. They still continue to be negative over these 3 months.
Yes, sir. Yes, sir. Up till now, till patient is 3 months old, and patient is not having these complaints as of now.
So you want me to believe that the lump has increased 5 times in size, but the child has not been like not showing failure to thrive or not showing feed intolerance?
No, sir. No.
Okay.
Probably he means that, that is what the parent says. They are not intelligent enough to notice any problems, and it is up to us to find out.
Right, sir.
Um,
It is
are
as
we,
per
are we,
history given by parents.
Okay, that's okay.
can we go to the next slide?
Family history was there was no history of tumors or malignancy in the family, and there was no history of any syndromic association. Coming to the birth history, uh, patient born out of a non-consanguineous marriage. The maternal age was 27 years, and she is a housewife. She attended regular antenatal visits and was a booked case. She underwent three antenatal scans, which were normal, and there were no any antenatal diagnosed lesion. But however, no fetal animal scans were done. There was no history of OC pills or any medications during pregnancy, no history of smoking, alcohol intake, no history of any major illness during pregnancy. And the father's profession is electric worker.
Why did you ask that?
Sir, since it has the swelling has increased over the short period span of time to almost triple four times the size of the initial size. So I am assuming it may be a kind of a malignant lesion. So some malignancies are found to have association with increased risk if a father is having certain occupation. Uh,
Like,
Sir, in cases of leukemias, rhabdomyosarcomas, and hepatoblastomas, there are certain further occupations are important pertaining to the causation of the disease incidence.
okay, proceed with the perinatal history.
Uh, the birth order is two. Second birth order. Uh, Full term normal vaginal delivered, hospital delivered. There was no any history of birth trauma, and it was uneventful delivery. Birth weight was 2.6 kg. Patient cried immediately after birth. No NICU stay or no respiratory distress at birth, and passed meconium and urine just after birth.
Is the maturity of the child anything to do with your case?
Yes,
The
sir.
child is full term.
Yes, sir. So,
You
sir,
might know. You please state it for the others who are listening.
okay, sir. Sir, prematurity and low birth weight are the established risk factor for the causation of hepatoblastoma, sir.
Premature and a very low birth weight.
Very less than 1.5 kgs are found to have association with the causation of the hepatoblastoma, sir. So these two are the established factors, these factors. So therefore, I mentioned full term here in this patient. Patient was a full term normal vaginal delivered.
Okay, proceed.
Coming to the immunization history received as per age, patient exclusive on the breastfeed, and there are no faulty feeding habits, and patient passes colic stools regularly. In the developmental history, patient attend developmental milestones in accordance with the age for the patient. So, sir, this is the summary on the basis of the history, sir. Patient is full-term normal vaginal delivered, having normal antenatal scans. Perinatal period was uneventful, asymptomatic till day 8 of life. Then notice the lump in epigastrium, which progressed to current size of 10 by 10 centimeter. There are no feeding intolerance and no associated symptoms.
Based on the history, what do you assume or presume?
Sir, since the lesion is since the lump is observed, noticed at the date of lamp, assuming it is a kind of a congenital thing. Uh, congenital lesion, which has enormously increased to the present size. So it may be, sir, in like sir, and in the upper abdomen also. So, sir, congenital liver lesions which have grown to this size may be the case in this case, or this can be, sir. Like it, since it is in the midline, it can be a rare case of teratoma, sir, gastric teratoma. uh, Other
Going
than
go
that, sir,
ahead.
I cannot conclude much on the basis of history, sir. I will need to examine the patient, and
Okay.
since it is a congenital thing, so the congenital arising lesions can be like,
The
Congenital,
baby
why
was
don't
born.
you would
If
call a teratoma congenital lesion?
no, sir.
Is
Teratoma,
that congenital?
no, sir. Congenital. Other than that, teratomas can be there in neonatal period. Teratomas can present since
The
it is.
teratoma assumes this size in the first 3 months. You'll have a lot of hemodynamic issues.
Yes, sir.
Okay, proceed.
Okay.
Proceed.
On general examination, a patient was examined in the well-lit room with proper exposure and prior consent. General condition was fair. Patient was active, alert, and playful. Was afebrile and heart rate was 126 per minute and was regular. Pulse was good volume. BP was 86 by 50 millimeter of Hg, and the respiration rate was 38 per minute. It was regular and abdomen thoracic. No evidence of respiratory distress. No use of accessory muscle. Coming to the anthropometry, uh, uh, all the weight, length, head circumference, and mid-arm circumference are within the 50th percentile for the age. Uh, there was no icterus, no pallor, no cyanosis, no clubbing, no lymphadenopathy, and no dehydration. Uh, on further examination, physics was appeared to be normal. Eyes were normal. Teeth were not yet erupted. Tongue was normal. No any body pigmentation or lesions were noted. Limbs were normal and there was no asymmetry. Spine was grossly normal. Genitalia was normal and anal orifice also normal.
How did you look for asymmetry?
Sir, by measuring, sir, span of the limb, sir, and comparing uh,
Span of the limbs. What do you mean span of the limbs?
by extending the, sir, uh, by extending the upper limbs. We-
What were you basically looking for asymmetry in the
Sir,
limbs?
is there any difference in the length in two limbs? Whether one limb is having more length and one is shorter?
Is that the only? Would you look at something else? Okay, proceed, proceed. We'll come back. What were you thinking of a Wilms tumor?
Sorry, sir.
Were you thinking of looking for a hemihypertrophy?
No, sir. Uh,
No.
sir, वो
What?
uh, Beckwith-Widman syndromes are associated with this hepatoblastomas, and the Beckwith-Widman syndrome, and also, sir, hemi uh, hemihypertrophy in isolation also can be present in patients with this liver lesion, hepatoblastomas.
You look at limb girth also. Okay.
Yes,
Not
sir.
only limb length and limb girth anomalies. Okay. Spine is normal, genitalia normal. Why look at the genitalia?
Sir, as a part of general routine examination,
That's
nothing.
all.
No more than that.
Yes, sir. Uh,
See, Prabhu is here, I am here. What were you looking for in the genitals?
Sir, any genitourinary abnormalities, it may be seen in cases with but not in this case, or Vagus
There
syndrome
is
can have
one thing in the
genitourinary.
genitals you should always look for when you have an intra-abdominal mass.
Yes, sir.
What?
Sir, testis, sir.
What in the testes?
Sir, whether testes are descended or not.
Yes.
But sir, this is the female patient, so that's why.
अच्छा. One more
I,
thing. You said the child is normal looking. See, I'll give you one. I am still not. Do you have a photograph of the child?
Sir, clinical photograph I have, sir.
एक बार दिखा सकते हो क्या? See, I'm trying to make your life easy if you get such a case in your exam. Did the child have good amount of fat like you expect in a child of 3 months? Because see, your history was very non-specific. If you had somewhere fit into picture that the weight gain, the child is like not well preserved or he's emaciated or something like that, then you could have actually, when sir asked you, okay, what do you conclude on the basis of history? See, you had one point that the child, the lump has grown to 5 times the size in 3 months. And if you're combining with something that is not growing well, then you could have put malignancy as the first differential diagnosis. And now sometimes what happens is the parent don't tell us the right thing because they are focused on something else very much. But if you think something is obvious on examination, you can gradually, you can elicit it out of them by talking it out.
Right, sir. But on a clinical examination, sir, patient was active, alert, and was not looking like a emaciated or kind of sick looking. It was not in this patient, sir.
Okay.
So I did not find any kind of malnutrition or failure to thrive in this patient. Uh, with as patient is 3 months old.
Okay. Chalo, carry on.
The rest of the system, central nervous system, patient was alert and conscious. Respiratory system, air entry bilateral equal, no adventitious sounds, and cardiovascular system, S1 and S2 heard, no murmur.
in an elective case, why are you people? I've always noticed putting alert and conscious. Okay, child will be alert. Okay, it may not. Just child is healthy. Nobody will keep an unconscious child there for you to examine on as an elective. So I don't think that is anyway. Avoid that. Go ahead with the local examination.
Okay, sir. Coming to the abdomen per abdominal examination on inspection, a fullness at the whole of the upper abdomen was noted. Fullness was occupying whole of the right and left hypochondrium with epigastrium and was extending up to the umbilicus of approximately 10 by 8 centimeter. Overlying skin was normal with dilated veins seen. There was no pigmentation, no visible peristalsis noted. Umbilicus was downwardly displaced and inverted. Hernial orifices were normal and renal angles were normal and no fullness was noted on inspection.
Anything else you want to add here on inspection?
Sir, this mark of biopsy needle you, you're
Okay.
pointing at?
That's a good point. Anything else? और क्या दिख रहा है?
Mm,
You see something on the skin? Through the skin?
dilated veins?
Yes.
Sir, I have mentioned, sir.
अच्छा, कहाँ?
Normal with dilated veins seen.
And do you think the umbilicus is actually inverted? मुझे फोटो में नहीं लग रहा. It might still be
Sir, inverted.
inverted. And do you want to tell something about fullness? Is it actually fullness or is it distension?
Uh,
See, fullness is something के जो normal depressions होते हैं, they have become full. But this seems to be a mass bigger than fullness. मेरे पास
okay, sir.
letter profile
But
नहीं है,
sir,
but
lower abdomen apparently normal on inspection, sir. So that's why I use terminology. There's fullness in upper abdomen.
wouldn't you call? I don't know. I've not seen the child, the letter profile, but I think it should be a distended upper abdomen. But anyways, be careful when your exam.
Okay, sir.
है ना? And you say right and left hypochondrium with epigastrium and extending up to the umbilicus. Okay. Umbilicus or umbilical region? What do you want to say here?
Sir, actually, this demarcation was done after palpation, sir.
Oh,
So
that's
it
okay.
was on palpation, it was reaching up to the umbilical region, but on a clinical inspection, it was looking like it is extending till the umbilicus. So that's why I mentioned here because I was not sure on the inspection, and later was confirmed on the palpation, sir.
Okay. Go ahead.
On palpation, sir, all inspectory findings were confirmed. The temperature was normal. A non-tender, ill-defined lump palpated, occupying the right hypochondrium, epigastrium, and left hypochondrium, extending up to the umbilical region, with size of maximum transverse diameter of 10 by 5 centimeter and maximum longitudinal diameter of 11 centimeter, which was firm to hard at places. The surface was smooth and edges were rounded. Lump extending up to the 10 centimeter below the right costal margin in the mid-clavicular line, and liver is not separately palpable. Fingers cannot be insulated between the lump and the costal margins, bilateral costal margins, and lump is moving well with the respiration and is non-pulsatile. There was no other palpable lump noted in the abdomen, no renal angle tenderness, and no other organomegaly was seen. All palpated.
It is firm to hard only at places, right?
Yes, sir. In some places, sir, it was firm, and some places it was hard, sir. Irregular kind of.
It was never smooth or soft at any point.
No, no, sir.
Okay. Right.
On percussion, sir, entire lump is dull on percussion. Liver dullness
Was the
starts at
lump,
15.
sorry, on palpation, was it nodular or was it smooth?
Sir, it was, sir,
Was the,
smooth. Surface was smooth. Edges were rounded.
okay. I didn't notice that line. Okay, sorry. Right.
On
Proceed.
percussion, entire lump is dull on percussion. Liver dullness starts at fifth intercostal space in mid-clavicular line, which is continuous caudally with the lump dullness. Normal tympanic note is noted over the rest of the abdomen, and no shifting dullness was noted on percussion. On auscultation, no bruit heard, and normal bowel sounds heard over the rest of the abdomen.
Yeah. Proceed.
So this is the summary after clinical and after the history and the clinical examination of the patient. A patient is a 3-month-old female, full-term normal vaginal delivered. Parents noticed a lump in upper abdomen at day 5, which was progressed to almost 3 to 4 times of its initial size within 3 months. Not associated with any systemic signs or symptoms, and firm to hard and non-tender lump, which was occupying the whole of the upper abdomen, extending caudally to the umbilical region, not separately palpable from the liver. Lump moving well with the respiration, and no free fluid and no organomegaly.
So,
Sorry,
what
sir.
is your clinical? So, what's your clinical
So
diagnosis?
based on this summary and examination, sir, I am assuming this patient having the neoplasm probably arising from the liver. The first differential I would like to keep as a case of hepatoblastoma as malignant lesion, since it has grown rapidly over 3 months, and it is a hard in size, and it is a painless. Hard in consistency, and it is painless and rapidly progressed. So I have kept my differentials, though age group is not in favor of the diagnosis, but this rapidly grown enlarged lump can be seen in hemangiomas also. But in this patient, there are no features of any distress, no features of CHF, no features of any vascular cutaneous lesions over the body, and no features of hypothyroidism. So the hemangioma can be the most common benign tumors which which occur congenitally and rapidly progress. But here in this case, the negative history rules out, like I kept it is the third differential because of this, and hepatoblastoma is the first differential. Uh, though in less than 10% of the cases, neonatal presentation of hepatoblastoma can be seen. So this can be the case.
What are your points, Ashwin, against neuroblastoma?
Sir, firstly, sir, neuroblastoma, uh, sir, the look of the patient. Firstly, the patient will be sick looking, and
Yes,
patient will have anorexia, and
the most important point.
this first point, sir. Secondly, sir, the age group, sir. Age group is also it is mostly in the infancy, but it is a neonatal presentation. May be seen in, sir, neuroblastoma 4S with the hepatomegaly case patients. Uh, Other than that, sir, the if the
Does neuroblastoma cause such huge sizes in 3 months?
uh,
Unusual, right?
Yes, sir. And again, sir, it is moving well with the respiration, is unlike with the case of the neuroblastoma.
Why didn't you think of hydronephrosis? A simple hydronephrosis, a huge hydronephrosis,
Yes, sir.
especially since it's present since birth and going
Right, sir.
insidiously. Child
But,
is
sir,
doing well, it moves well with respiration, the surface is smooth. You can have a firm to an tensile cystic.
Hence cystic
Hyd-
hydronephrosis, yes, sir.
yes, sir. But because the renal angle were normal, but there was no fullness, and there was no
No, in
any.
children, children, you need not have a renal angle fullness in the hydronephrosis. It is more of an abdominal structure. It dilates into the. How many infant hydronephrosis pyeloplasty you go in? You will see the pelvis towards the umbilicus.
Right,
It
sir.
doesn't fall back and stick to the thing. You will see it is more anterior. It goes into the abdomen and pushes the thing. You have to go really down to get it into the abdomen. So you need not have renal angle fullness often. Always. So I think you could have put it as one of the differentials. I understand firm to hard is unusual, and it is usually uniformly tensely sustained.
Right,
Okay,
sir.
but then that should have been a differential rather than a teratoma or a gastric teratoma.
Yes, sir. It is
Now
less
you
likely. So teratoma to grow is such a big size, and and not having systemic like symptoms of that.
now you said it is a hepatoblastoma.
Right,
Okay,
sir.
in a why didn't you think of an infantile uh, hemangioendothelioma?
Sir, infantile hemangioendothelioma will have concomitant CHF features also, sir.
Concomitant?
CHF, congestive heart failure features because of the shunting. And patient typically does not have any kind of a respiratory distress at birth, no NICU stay, and on examination also respiration was quite well, and not distress in distress as well, and no cutaneous lesions also, sir.
So you put it as third and the diagnosis. Child is absolutely normal, healthy. Why couldn't have been a hematoma? That will fit with your congenital
Yes,
present
sir.
since birth.
That's why, sir, I kept as a second diagnosis. It also fits that it may have a
Or
congenital
then you
diagnosis.
think a hepatoblastoma is present at birth.
Uh, Sir, congenital hepatoblastomas are been reported in the literature.
Excellent, excellent. I wanted that answer. Very good, Ashwin. Okay, there is a small subset. Go read up about it. Congenital hepatoblastomas have been known to occur.
Yes.
Like any other tumors, one of the tumors, can neuroblastoma be congenital?
Neuroblastoma, sir.
Can it be congenital?
Uh, Sir, congenital antenatal detection is there in the
No, I'm
neuroblastoma.
asking you a question. Is there a quantity called a congenital? Yeah, antenatally detected neuroblastoma. What happens to that? Will you be very worried? What will you tell the parents if you have an antenatal diagnosis of adrenal tumor?
Sir is asking you about the clinical course of these.
Sir,
No, this is not regarding this case. I'm just giving you a hypothetical question.
अच्छा sir, in case of neuroblastoma, it is a congenital neuroblastoma.
The clinical course क्या होता है?
Sir, it will be the favorable course, sir. It will have
Like,
favorable.
like,
Uh, like sir, like in infancy, it
It
is
will
a
undergo, the tumor will undergo what?
sir, resolution and spontaneous resolution can be there.
reg-
Spontaneous resolution.
regression.
Regression.
Okay. And, or it can, see, somebody is putting answers in the chat box, which our convener, Dr. Evangeline, specifically asked you people not to do. What happens is congenital neuroplasma regress. Uh, it is, to the best of my knowledge, they don't become ganglion neuron. Okay, they regress completely
Hmm.
or almost completely. Rather, they don't become ganglioneuromas to the best of my knowledge. Okay.
Oh,
Anyway, please check on that. So please remember there is to the other students who are listening, there's an entity called congenital neuroblastoma, that hepatoblastoma. That is the first thing which came to mind when he presented this, but I don't think they attained this size. Anyway, proceed.
Can it
So
be a political cyst? What are your
sir,
points in favor? What are your points against?
sir, firstly, sir, choledocyst is very unlikely to have such a big, huge mass. Secondly, sir, the mostly the
I
in,
disagree. I disagree,
I
Ashwin.
also disagree.
Okay. Reason we have operated, it's not uncommon, quite common. Choledochocus reaching into the pelvis.
Okay, sir.
Okay. So they present with their suits sometimes. The bigger ones come early in infancy.
Sir, second, and the another point will be, sir, mostly this patient, coldococyst will have jaundice, sir. Patient will present with jaundice.
No, not necessarily.
Ashwin, this answer you can best answer as, sir, I will put my points in favor and I'll put my point against.
Okay, sir.
ठीक है ना, बट लगा देखो, एक तो ना, whenever you're in an exam, don't use the word but seems like you're trying to counter something. It's a discussion and you should tell what are the points in favor for a choledochal cyst here. Age? Yes, no.
Uh, Eight, sir.
Can a
Yes.
choledochal cyst happen at this age?
Yes, sir.
Location?
Yes, sir. Mostly in the right side, on the right side of the abdomen.
हाँ, तो लोकेशन भी फेवरेबल हो गया. एंड इफ इट इज अ ह्यूज टेंसिस्टिक, तो तुम्हें स्मूथ सरफेस फील हो रहा है, बॉसोलेटेड नहीं फील हो रहा,
Yes,
इरेगुलर
sir.
नहीं फील हो रहा, राउंडेड मार्जिन हो रहे हैं,
Yes, sir.
राइट?
Right. Yes, sir.
The child does not have jaundice, but that's possible with a choledochal cyst. Now,
Right,
what
sir.
are your points against a choledochal cyst?
Um, Against the jaundice, not
Number
patient
one,
is not
jaundice is
having
not there.
jaundice.
Number
Is
two,
it's against
it was
passing
felt for the
colic.
first time in the
हाँ sir.
for the first time the lump was felt in the
Epigastrium, sir. मतलब mid abdomen,
midline. तो unlikely,
midline. So it
midline
is
में नहीं फील
unlikely
होगा
to.
मोस्टली. हाँ.
Yes, sir.
What was the antenatal scan? Was it done?
Sir, antenatal scans were done where there was no any antenatal detected lesion in the scan, but
Usually, a choledochal cyst is detected antenatally.
yes, sir, they do detect, they are detected. They may be detected.
Can it be a duplication cyst?
Yes, sir.
Points in favor, point against.
Uh, Again, sir, uh, point against, sir, patient is not having any symptoms like vomiting, hematemesis. If we are
So no GI symptoms.
no GI symptoms,
है ना?
uh,
So duplications always have GA symptoms.
sir, mostly, but not always.
Mostly.
Yes, sir. Vomiting will
Vomiting.
be there.
Vomiting. How many children have you seen with duplication who presented with vomiting? It can be there. Mostly word is not right, I think.
Okay, sir. And sir, consistency is also against the duplication cyst, sir.
If it is a tense duplication, इतना बड़ा duplication होगा तो tense ही होगा ना.
Yes, sir.
Unlikely to be a tubular one. Yeah.
Yes.
Especially when you give a history which is not pointing towards malignancy. So you have to include such points and differentials. And the best way, whenever somebody asks you what are the chances, always say points in favor, points against.
Okay, sir.
Sir, shall we go to investigations?
Okay, yes, sir. Yes.
So how would you investigate this child?
Sir, I would like to confirm my diagnosis by doing, sir, ultrasound of the abdomen to know the organ of origin,
Okay.
whether it's and its consistency, whether it's solid or cystic, and number of lesions, and to get idea of basically the organ of origin mainly. So I will firstly do this, and along with that, basic blood investigations with tumor markers also, sir. Since I am assuming it is a case of liver malignancy, hepatoblastoma, so I would like to go ahead with the tumor markers and complete basic blood investigations.
What tumor markers?
Sir, alpha fetoprotein.
What is the normal alpha fetoprotein for this child?
Sir, it will be with in hundreds, sir. Like 80 to 100 nanogram per ml will be the normal for the age uh, for the 3 month baby.
And for an 8-day-old baby?
8 day old, sir, it will be somewhere around it is a range, sir, actually 30,000 to 80,000 nanogram per ml.
So what's the half-life of AFP?
Sir, it is 5 to 7 days.
Very good.
5 to 7 days is the half life of the AFP, sir. Uh,
So you said you'll go for an ultrasound, you'll go for routine blood investigation, means hemogram electrolytes, and you said you'll go for tumor markers. What tumor markers? One
along
is
with
the
that, sir, LFT also and viral markers also, sir.
viral markers also. Which ones?
Uh, Sir, hepatitis uh, A, B, C.
Why?
Mm,
What is on your mind?
For this case,
No, sir. Actually, in cases of liver malignancy, we tend to do viral markers, but in this case, we are not assuming it as a, like having a like in SCC, sir. The viral hepatitis is a predisposing factor, but here in this case, we are not suspecting anything like that. So, viral markers, maybe, sir, may not be
now
done.
you mentioned AFP. Where is it secreted? Sir
Sir,
asked the levels. Where is it secreted?
uh, uh, liver,
विशाल
sir.
इसमें सुबह चेक कर लेती हूँ। हाँ? विशाल सुबह चेक कर लेते हैं, वैसे भी अभी तक तो बना ही नहीं होगा।
Yeah, proceed. Where do you think the AFP is secreted?
Uh, Liver, sir.
Yeah, where?
Uh, Sorry, sir, I don't remember this.
Okay, regarding this viral hepatitis, what does viral hepatitis to do with the AFP? Is there any link? You mentioned it. See, it's also secreted by regenerating liver, no? So
Yes, sir.
always remember that. So even in viral hepatitis, there's one condition where you can have AFP elevation also. So, but you mentioned the child was not sick, doesn't have any issues. That is why it is unlikely. Regenerating liver also secretes increased amounts of AFP.
Yes, sir.
Okay. And sir asked about these viral markers. I don't know why you should do it in this particular case.
So, sir, no, sir, I will not do viral markers, sir.
You can do it for as a surgical protocol, not for thing. Yes, if you suspect a pre-existing liver disease causing that malignancy in a pre-existing disease, then you have to do all this.
Yes.
Okay. And investigation is you said ultrasound. We know ultrasound why you are doing all that. So why you said you will do an alpha fetoprotein. Okay. And then do we have the values for this particular child?
Yes, sir. Sir, these are the values, sir. Sir,
I have to forgive me,
sir,
bro.
I will read it out, sir. Sir, hemoglobin is 8.1. TLC is 16. Platelet is 8 lakhs. Uh, Sir, alpha fetoprotein is 4 lakh, 1 lakh 49,000 nanogram per ml.
You don't have any LDH. Yeah, it is there. Okay. Right. Okay. So what do you infer from this?
Sir, patient is having, sir, anemia along with, sir, thrombocytosis with raised alpha fetoprotein, sir. So, on the basis of this report, uh, there are more chances of it being hepatoblastoma, sir, because thrombocytosis is also there, and anemia is also there, and AFP also raised for the age.
Still doesn't do mesenchymal hematoma.
Sir, mesenchymal hematoma, sir, in mesenchymal hematoma, seldomly, sir, mildly elevation or AFP values are normal. So, this
Okay,
rules out.
agreed. So what is your next investigation?
Sorry, sir.
Next, what would you like to do next?
Sir, after
You have the ultrasound for this case?
yes, sir, this is the
Yeah.
ultrasound, sir.
Okay.
Ultrasound suggests that liver is grossly enlarged and shows a sorry, sir, large, well-defined heterogeneous mass, predominantly in the left lobe, quadrate and caudate lobe, and having small multiple hyperechoic masses also. Malignant nature cannot be excluded. Other things are normal. So on the impression, gross hepatomegaly with large heterogeneous mass, very malignant, very hepatoblastoma, as they reported on the ultrasound.
What else would you like to see on that ultrasound? They have given you this ultrasound. You would have, suppose you were doing it,
Yes, sir. Sir,
a supervised ultrasound.
sir, though they have mentioned the organ of origin of the tumor, but I am more concerned and more interested to look at the intrahepatic biliary radicals.
Intrahepatic biliary radicals. What for?
Uh, Whether this lesion is compressing the bile ducts or not, and also, sir, size of a portal.
How many hepatoblastomas causing bile duct, biliary radical compression
Sir,
and all that?
rarely, sir. No, it's not routine, not not
Then why are you
frequent.
looking at that in an ultrasound?
No, sir. But just I was finding what is not there in the what is lacunae in this report. So they have mentioned the organ of origin. Uh, Other than that, uh,
No, you would look at the organ of origin. I have not read the full report. Okay. I am just reading it now. Now, what are we more interested in a lesion? Whether the lesion has gone beyond the liver,
yes,
whether
sir.
there's any extension into the vascular structures,
Yes, sir.
whether the portal vein is free or not, whether the
Yes, sir.
hepatic veins, because an ultrasound as a Doppler
Yes.
is more sensitive.
The signs of portal
Yes.
hypertension we will look
No,
for
no,
in
no,
it.
no, no, no. Don't look at signs of portal hypertension. Go look at whether the portal vein there is a thrombus or not, whether the hepatic veins are free, the IVC is free. Okay,
Okay,
right.
sir.
Right. Okay. Then the
Uh,
ultrasound is what would you do next? You got an ultrasound, you got an AFP. What is your next investigation of choice?
Sir, I would like to go ahead with the CCT at the abdomen and the chest, sir.
What type of CT scan would you like to do here?
Sir, sir, triple phase CT scan, three
What
phase
is
CT scan.
the
This triple face.
Sir, triple phase has three phases: arterial phase, venous phase, and sir, delayed phase.
what do you
What
want to
venous
see
face?
in each of these three phases? सर कुछ पूछ रहे थे शायद.
Sorry, sir.
Sir wants to know what would you like to see each of these three phases?
Sir, in the arterial phase, I would like to see on the arterial enhancement if whether the lesion is enhancing on the arterial phase. Uh,
In each of the three phases, you see for enhancement. But what does the enhancement in the arterial phase tell you? I mean, what is the reason of enhancement in the arterial phase?
Sir, enhancement in the arterial phase means that the feeder of the tumor is from the hepatic artery.
So it shows you the tumor arterial vascularity.
Yes, sir.
And how much time after injection do you take the arterial phase?
Uh,
How many minutes?
Sir, 2 minutes to 3 minutes.
See, you fell into my trap. Huh? See, we are all old bandicoots.
They use
Huh?
common sense. Injection दिया
Yeah, I have asked how many minutes.
and
It's
you
in
get
seconds. Within the first 30 seconds is when you get the arterial
arterial
phase.
phase.
Okay, you mean to say a drug will take more than 2 minutes to reach. So the first 30 seconds is the arterial phase. Now next,
Next, sir, venous phase, sir.
Is it called the venous phase or there is something before venous?
an adjective or a
Portal phase. Yes,
uh,
portal venous phase.
portal venous
Portal venous
phase.
phase. Yes, sir.
Timing? Now, how much time after the injection you want the portal venous phase?
5 to 7 minutes, sir. Sir, I don't
Oh my
I
God.
don't know the
Oh my
exact
God.
answer.
Common sense लगाओ देखो. See, let's use common sense so you'll remember easily. You give an
1
injection in
minute.
the peripheral vessel,
Yes,
it will
sir.
go to the heart and it will come to the liver through the
Yes, sir.
artery. और आर्टरी से जाएगा वेन में. अब सर ने तुमको बताया आर्टेरियल फेज है 30 seconds. How much time do you think it will take from hepatic artery to portal vein?
Another 30 to 40 seconds, man. Okay. Around 60 to 80 seconds
Yes.
will be the. Yeah, it varies. Some places they say a longer thing, but it can go up to 120 seconds also. So around 60 to, yeah, you can say your second minute, 60 to the second minute this happens. Okay, portal
In the
vein. So
arterial
it's
phase,
little slower. It has to go through the sinusoids. So it is slow. It takes another minute to reach the portal vein.
Yes.
Okay. And then
So what do you see in the portal venous phase? Like arterial phase में you saw arterial vascularity, यहाँ पे क्या दिखेगा?
Uh,
Obviously portal vein
yes, sir. Portal
and
vein.
and
Uh, so tumor enhancement, since these are the majority of the portion of the liver is supplied by the portal vein, and so
and portal vein
lesions, sir, tumor
and
enhancement.
hepatic vein का नहीं दिखेगा फिर?
Yes, sir. Hepatic veins. Yes, sir.
which is why are these portal and why are we very, very worried about these portal and hepatic veins and in those phases? What do they give us?
Sir,
What
because
information?
to sir have sir uh, classify the to a division on the basis of the sir CT scan, we divide these tumors in the pretext classification and also to plan surgically, sir.
Okay, maybe right. Okay.
The third phase,
Sir, delayed phase,
Washout phase.
washout phase, sir.
delayed washout or equilibrium phase.
Yes, sir.
Equilibrium.
Time
2 minutes, sir.
हाँ चलो 3 to 5 होता है, ठीक है.
Okay, sir.
This time you
Yes.
took a good guess. And you're looking for what? 1, 2, 3?
In sir delayed phase,
Yes,
sir, complete washout of the
very good. Number 1 washout. Number 2
sir, pattern of enhancement, whether it is centripetal or centrifugal enhancement, peripheral, central.
और main 3 things. One is washout. Second is what type of tissue इसमें enhance होता है?
Uh,
Particular type of tissue जिसमें इतना लेट होगा.
sir,
Fibrous
necrose
tissue.
tissue.
Fibrous tissue. Necrose तो होगा
Nec-
ही ना enhance. Necrose tissue में blood कहाँ से जाए? किसी भी
They
phase में
don't enhance at all.
blood will not go there at all. So it is for washout number 1, fibrous tissue and bile ducts.
Okay, sir.
Sometimes we convert 3 phases into 4 phases. What is the fourth phase?
Sir, fourth phase is the actually non-contrast phase.
Very nice. You read about it. Good. So आपने देख लिया CT scan देखने के बाद how would you what is the type of diagnosis that you'll be able to make? Yeah, इसका हुआ है CT scan.
Yes, sir.
What are the findings?
Sir, there is a sir large heterogeneous mass occupying whole of the left lobe of the left liver and encroaching onto the right part of the liver, and it's a sir a heterogeneous mass without any calcifications. Uh,
So when you're describing the extent and you're talking about a CT, would you want to talk like this? Left half, right half?
Extending into the right, and it's like, I mean,
no, sir.
can't you be specific about your, yeah. Do you have a spiral? Do you have a spiral video?
Sorry, sir.
You must have done a spiral CT. Is there a video?
Sir, this is the only film. This is the film, sir.
Okay.
Oh, I think so Chachana room में CT scan machine नहीं है ना, they get it done from outside.
Yes, sir.
Okay.
So what areas of the liver are involved precisely? How do you tell what are the areas in the liver? How do you describe the involvement of the liver?
Sir, the description basically uh, based on the sir 8 segments and 4 sections, sir. This
नहीं,
division is takes place with the help of hepatic veins. So the 8 segments is divided into 4 sections with the help of 3 hepatic veins. So left lobe of the liver has 2 sections comprising of the 2 and 3 lateral, left lateral, 4A, 4B. Uh, um, then
so when you know this classification, अब बताओ this tumor is involving which segments?
uh, Sir, on this film, sir, I can't tell exactly because at the various levels we need to see for the various segments, sir. Mm,
So that is what you're supposed to do. You should sit with
No,
this
with this,
and with the
see,
results.
basically static films don't mean anything to us.
yes, sir.
Okay. Anyway, it doesn't tell me, yeah, it doesn't give me much information. Now we'll have to read out the report now
Yes,
for
sir.
us to understand.
Sir, report also didn't comment on the involvement of the segments or sections, sir, in this particular case. So they have said large heterogeneous mass involving entire left lobe and extending into the right side of the liver of 18 by 10 by 5, 10.5 by 11.5 centimeters with the central areas of necrosis, with the portal vein is completely compressed and lesion is compressing pancreas inferiorly and pushing kidneys inferiorly.
Okay. So we don't have any idea of the heterogeneous mass lesion, the extent of this mass. So can we give a pretext for this?
Sir, uh, s- uh, since sir, I'm assuming like the right side of part of the right lobe of the liver is spared, so and three sections are
Yes.
involved.
They say extending into the right side. Okay.
Yes, sir. So I'm presuming it is a pretext three, sir.
Can you expand on the pretext?
Sir, pretext is a pre-treatment extent of the liver tumor, sir. Sir, this tells about the areas of involvement and to
Actually,
further.
it's been described pre-treatment extent of the disease.
Yes, sir.
Okay. And okay. Hmm.
Sir, it has pretext 1, pretext 2, pretext 3, and pretext 4 based on the areas, sections of the liver
No, that
involved.
all of you know. That all of you know. This case is presumably pretext three,
Yes, sir.
large tumor, child is doing well. You have got a there's something important. Portal vein is completely compressed. So I
Yes, sir.
need to know what do you specifically need to know there.
Sir, it's the annotation noted by P. So, involvement of the main portal vein or branch of the portal vein denotes P. So, sir,
It
uh,
is only compressed. The portal vein, you don't have a thrombosis.
yes, sir.
So it is still annotation positive.
Mm. Sir, invasion of the portal vein is considered as annotation for P.
They have not said invasion.
Yes, sir. So it is if it is only abetting or compressing, so it will not come under the criteria of the annotation. So it will not
There
be.
is there is no mention. Just a minute. I'm just seeing the report. Visualized from field set infective etiology, no lytic, no free fluid, both adrenals ureter. They have not mentioned anything about the nodes in the portal area. Is it important?
Uh,
What is your idea of nodes in a hepatoblastoma? Does
sir,
hepatoblastoma cause nodal metastasis?
yes, sir.
Yes,
Uh,
sir.
sir,
Where it doesn't.
yes, sir.
How
In
many
sir,
hepatoblastomas we have operated? Do we have any portal nodes? No. Okay. It causes only lung metastasis. Okay. It is a tumor which is known to cause regional nodal metastasis.
sir, but in COG classification in Evans staging, sir, they have mentioned that stage 3 has involvement of the lymph nodes.
No, but it's unusual.
Yes, sir.
Just go through all the cases which we have done so far. Uh, Rarely do you see nodes in hepatoblastoma.
Okay, sir.
More often you see pulmonary
Yes, sir.
metastasis.
In 20% cases, we
ठीक है
present
सबको ठीक
lung
है
pulmonary metastasis.
हमारा क्या है उसका
Okay, then
दो घंटे
now
पहले
you
वो
have
ये
got
उन्होंने पाइप नहीं करा था मैंने कहा था धनिया से वो बता
I
देंगे
assume the CT chest is normal. They just
Yes, sir.
infective etiology, that's what they put.
Yes, sir.
And based on this, how will you proceed?
Sir,
Because they say we are short of time.
yes, sir. Based on this, sir, I have almost confirmed my diagnosis with the help of the tumor marker and the CT findings, sir. I am assuming it is a pretext hepatoblastoma. So, at our institute, sir, we follow SIOPL guidelines.
No, you have not. What is the risk classification of this tumor?
Sir, risk stratification is based on, sir, a pretext only, sir.
Yeah, but in this tumor, what do you think is it?
Sir,
It is based on pretext only.
yes,
So you
sir.
should tell me
It
now.
on the SIAPL criteria, it is standard risk group, sir. Because high risk,
Standard.
it is not having metastasis, and alpha fetoprotein also not
AFP
less
is
than 100.
elevated. Pretext 1, 2, and 3, elevated AFP with
Yes,
no
sir.
annotation factors.
Yes, sir. So it
Okay,
is the
that is a
standard risk.
standard risk.
Standard.
So what would be your management strategy in this case? Can we be fast because there is so much more in a
Sir.
hepatoblastoma? We are getting bogged down in lower levels.
Okay, sir. Sir, as such in SIAPL, sir, that we follow at our institute, there are if the imaging and the age criteria are matching to the diagnosis of the hepatoblastoma, then there is an AFP is also raised. There is no
No, no,
need
I'm
for
talking of
biopsy.
this case. What will you do now?
Yes, sir. Sir, I will start with the sir neoadjuvant chemotherapy for this patient, sir.
Would you like to do a biopsy before that?
Yes, sir. Biopsy
Why,
also.
why didn't you? Biopsy also.
Yes, sir.
In
Sir,
your
that
in your institute, you do upfront chemo without biopsy,
no, no, sir.
or
Sir,
no?
in
Uh,
in SIAPL, sir, there is no need of biopsy if patient is having the presentation as according with the age of the hepatoblastoma, and AFP and imaging are representing the hepatoblastoma. Then there is no need of biopsy. But here in this case, the age is atypical. So I would like to go ahead with the biopsy first, sir.
what biopsy?
Sir, true cut biopsy, image USG guided true cut biopsy.
You call it a true cut, or can you qualify it
Both
better? Huh?
uh, wide bore needle biopsy,
You said it right. Core needle
core
biopsy.
needle biopsy,
Can you make it more sound and more correct?
tissue diagnosis.
No, you do it. Uh, how do you do that core needle biopsy?
Sir, ultrasound guided, sir, USG guided.
Why? Why should it be ultra? You got mass everywhere. Anywhere you can poke it in.
So just to stay away from the vasculature, sir, that's why. So it may
Is
not
that
lead, it should not lead to torrential bleed or a kind of
that
miss.
is one? Is there any other reason why you do guided
Sir,
biopsies?
there are chances of necrosis. So we should not take biopsy from the necrosed tissue.
See what type of biopsy? I have not said it's just core biopsy. You should. It is a coaxial, done by the coaxial method. It's a coaxial core needle biopsy. What do I mean by coaxial biopsy? Coaxial, using a coaxial technique. Are you aware?
No, sir.
Huh?
No, sir.
What is the size of the uh, core needle biopsy you want to use? Biopsy needle?
Sir, 2 mm, sir.
What is the a needle size comes in 2 mm? It comes in gauge, right?
Okay, sir.
So what gauge needle you would like to use? If you're not aware, I'll tell you. It's a 16 gauge needle. Push through a 15 gauge coaxial needle. What is this coaxial method? Ultrasound guided. You are supposed to take 7 to 10 cores. Okay. Each measuring 20 to 30 mm. Okay. And where are these cores supposed to be taken from? From various parts of the tumor. That is why you need your all parts of the tumor. And then also from the normal liver tissue adjacent, immediately adjacent to the tumor for comparison.
Okay, sir.
Okay. And this needle biopsy should go through the part of the liver that is going to be resected in the future. You don't go through the right lobe, right? Okay. Try to be as close to the tumor so that you don't seed it. That is more important for HCCs rather than hepatoblastomas, but still, you go through the part of the liver by your guidance, ultrasound or CT guidance, through a part of the liver that is eventually going to be resected. Okay, that is the coaxial method, core needle. You put a needle and through that you put another needle and then you take out these cores. You need at least 7 cores of diseased liver and normal liver for comparison, around 2 to 3 cores you need. Okay.
Okay, sir.
This is how the biopsy should be done. Okay, for a liver. Okay, right. And then why are we taking it at different areas, Ashwin, of the tumor? After all, one biopsy is going to give you a diagnosis. Why are we taking 7 cores in different areas? Are you tired?
No, sir.
Hmm.
I was thinking, sir.
You see,
Different
they can
method
be. Uh-huh.
differentiation, different differentiation of the tumor can be seen at the different level of.
You're getting close. See, there'll be foci of small cell undifferentiated
Yes, sir.
thing in a
Yes, sir.
larger lesion. That
Yes.
immediately
Upstage the and
increases
it will high
the
risk.
risk
Yes, sir.
stratification.
High risk it will be.
Okay.
Yes.
So that is why we need to take from different parts. Now I believe you've got only 5 more minutes. Um, you want to the diagnosis. Do you have the histopathology of this case?
Yes, sir.
I won't be asking questions like where is the AFP normal and all that. I assume you people know. Huh?
Yes, sir.
Pure fetal and in small cell undifferentiated. Liver biopsy, can we go? Features are consistent with hepatoblastoma, mixed epithelial and mesenchymal subtype.
Yes, sir.
Okay. Not very helpful. IHC not done.
Not, sir.
Okay. Now you said the age is atypical and you have some annotation factors. Anything more than an IHC biopsy you would like to do? Would you like to see the biology of the tumor, molecular biology? Okay, we leave it for another day. Then, what chemo would you like to do for this case? Obviously, you got to confirm next is chemo.
Yes, sir.
What is your
So
preferred chemo for this
As
case?
per SAPL, sir, neoadjuvant
No, what will
chemotherapy.
you do? What will you
Yes,
do?
sir.
Huh?
Cisplatin monotherapy, sir.
Huh?
Cisplatin monotherapy.
Cisplatin monotherapy. Okay, because it is standard risk.
Yes.
Okay. Quickly, what are the problems with cisplatin?
Sir, can have, sir, ototoxicity and renal toxicity. Other than that,
And
renal
lenotoxicity.
toxicity, myelosuppressions, vomiting, and
How do you reduce these problems?
sir, sodium thiosulfate is a drug which has now been used to reduce the ototoxicity in these patients receiving
Okay.
cisplatin.
Okay, then
Sir,
nephrotoxicity, how would you reduce?
sir, with the help of hydration, sir, during the chemotherapy, we tend to give hydration therapy for 6 hours prior to delivery of the
Well,
chemotherapy.
pre-hydration.
Rehydration, yes, sir, before this 6 hour.
Okay. And any other problems with cisplatin?
Uh, Vomiting and, sir, bone marrow suppressions like in other.
So
Uh,
when will you assess the response to cisplatin?
Sir, firstly, sir, baseline audiogram should be done to see for any previous before starting the
No,
chemotherapy.
that's okay. Once you have started chemotherapy,
Yes,
all that is a given, doing your baseline audiogram and all that. No?
yes, sir.
And after you start the chemotherapy, when do you assess response?
Uh,
Assuming it is a responsive tumor,
yes, sir.
when would how long do you take?
Sir, follow-up
Hmm.
protocols are there for audiometry after giving chemotherapy.
No, no, I'm not talking of cisplatin follow. The effects I'm looking at the tumor. Obviously, when will you assess the tumor response? I'm talking of tumor response.
Okay, sir. Tumor response. Okay, sir.
Hmm.
After receiving, sir, four course of this, sir, cisplatin monotherapy, I would like to go repeat three triple phase CT scan of the patient and to see for the post text, sir. To see for the feasibility of the resection based on the post text classification, whether the what sections are
Suppose the
involved.
response is not very good. What will you?
Uh, if it is not very good, then.
Would you
We'll
add
need
something?
to we'll need to add, sir, doxorubicin into this chemo.
I hope you know all of the problems with doxorubicin.
Yes, sir.
Okay, right. Now, what sort of myopathy does it cause?
Sir, cardiomyopathy, sir.
What cardiomyopathy?
Uh,
So, dilated
Dilated
cardiomyopathy.
cardiomyopathy.
Okay. Now, Prabodh.
Sir.
Hmm.
Okay, Ashwin, let's talk something about genetics. Are you okay with that? Have you read about it?
Yes, sir, little bit, sir. Yes.
A little bit मोटा मोटा ही बात करेंगे. What is the most important gene which is in vogue for hepatoblastoma? This gene is, mutated in 90% of the patients.
Yes, sir. WT1 and
W नहीं hepatoblastoma की बात कर रहे हैं हम लोग.
okay, sir.
Not yours.
Which is the most common gene which has been found to be mutated. हमारा एम्स का भी एक पेपर है, but forget about that. Word over. One gene which is very common here.
CTNNB, sir.
Very good. CT
NNB.
NNB1.
NB1. Sorry, CTN.
CTNNB1 gene. This is mutated in nearly 88.7% patients of Wilms tumor. So, what is the pathway on which this acts?
Uh, CPN.
I've seen examiners coming to an institute asking this question frequently. इसलिए पूछ रहा हूँ. It is the WNT pathway.
WNT pathway. Yes, sir. WNT pathway.
WNT beta catenin pathway.
Beta catenin. Yes, sir.
So what happens is when the gene is mutated, the ability of the cell to metabolize this product is decreased. So there is accumulation of beta catenin in the cytoplasm. So then because when it becomes an overdose, it migrates into the nucleoplasm inside the nucleus, and that is where it starts causing problems.
Okay, sir.
Okay.
Why do we? I'm just asking some miscellaneous questions which are asked in exams. One
Okay,
more
sir.
question. Suppose you have a biopsy report which says it is hepatoblastoma. Do you still need an AFP? A patient comes to me with a triple phase CT scan जो आपने दिखाया,
Yes,
and he
sir.
comes to me with a biopsy report which says it is hepatoblastoma. I have
Yes,
the
sir.
pre-tech staging. I think it's a low-risk hepatoblastoma. I can straight away go and start cisplatin monotherapy, or
No, sir. It will, sir. Value of AFP will determine this risk stratification of, category. If it is less than 100, then I will consider it as a high risk and will start accordingly the chemotherapy.
Okay, so one is risk
Anything else?
stratification.
Anything
Other,
else?
anything else? Yes, that's what I'm asking, sir.
Sir, to have a response in follow-up, sir, after chemotherapy, I will need to follow the response, whether it is either getting down or is it like static, to follow up and see for the
Okay,
response.
so during the treatment phase, you're following up the progression and the resolution of the disease.
Yes, sir.
ठीक है, ट्रीटमेंट खत्म हो गया,
Yes,
उसके
sir.
बाद भी कोई रोल है अल्फा फीटोप्रोटीन का?
Yes, sir. To see for recurrence.
Very nice. What are the favorable prognostic factors in hepatoblastoma? What are the unfavorable prognostic factors in hepatoblastoma?
Sir, favorable prognostic factors are, sir, firstly, sir, histology. The fetal type is very good favorable prognosis.
So fetal histology से पहले कुछ बोलना चाहोगे? You're missing one word.
Pure fetal.
Yes, pure fetal histology.
Pure fetal, sorry, sir.
Low
Pure
mitotic.
Meaning the whole, all your biopsy, all your course turn out to be a thing. It's a pure fetal histology.
Yes,
As I said, the problem in hepatoblastoma is the what do you say? You have areas of undifferentiated elements in between,
yes, sir.
which
Yes,
increases.
yes.
Okay.
Then, sir, other prognostic factors are AFP values. If it is less than 100, then it is a poor prognostic factor. Third is
If it
the
is more
chemotherapy
than,
response.
and if it is unfavorable कब होता है? When it is more than?
AFP, sir?
Yes.
Uh,
Unfavorable बोलने के लिए it should be more than
1.5 lakhs? नहीं,
1 lakhs.
1 lakhs.
अच्छा, प्रीटेक्स्ट जो हमने सर ने डिस्कस किया था, प्रीटेक्स्ट 1 to 4,
Yes,
उसको
sir.
रिफाइन करने के लिए वी यूज सम अदर एनोटेशन फैक्टर्स, राइट?
Yes, sir.
वो क्या क्या होते हैं?
Sir, annotation P means the involvement of the main portal vein or branches of portal vein, two branches of portal vein, right and left. Other than that, sir, caudate lobe denoted by C.
वेरी गुड.
Sir, IVC involvement or major hepatic vein involvement by V, sir.
Hmm.
And sir, metastasis by M.
Very good.
Uh,
Something for N.
uh,
N for Nagpur.
sir, nodal
Very good. Nodal metastasis.
nodal metastasis
Then
N.
you have H. H for
Sir,
Hyderabad.
extra hepatic also E. E is for extra hepatic.
E for extrahepatic. Very good. H for
Uh,
H.
Hilar.
Nahin. H for. I'm sure the next guess would be right.
Sorry, sir.
HEM.
Extra hepatic metastasis.
No, hemorrhage. Intraperitoneal
Hemorrhage.
hemorrhage or tumor.
Hemorrhage. Yes, sir. Sorry, sir.
ठीक है?
Yes, sir.
Okay,
What
I
is the
think we are coming to the end of this. Can I ask you one question? Do you have any idea about the functional hepatic reserve?
Sir, FLR. Sir, functional hepatic reserve is something which will remain after excision of the involved tumor. Excision of the tumor, the remnant will be considered as the functional liver residual, FLR. Uh, sir, 25% of the FLR is considered adequate in the cases of the hepatoblastoma and pediatric age group. Uh, but the terminology of FLR is more important and more concerned in cases with the SCCs because it forms with the background of this chronic liver disease and diseased liver.
How
Whereas,
do you calculate if functional liver reserve? You're talking of functional reserve, but how do you find out what is the functional reserve of any particular child?
with the help of imaging, sir,
What imaging? This is a specific type of imaging.
sir, uh, PET scan,
You would like,
sorry, okay,
would you use ICG for that?
ICG can also be used, sir.
What will you use in ICG? Okay.
Gadolinium
Is there any scoring system?
for FLR, sir.
You find a scoring system to find the FLR?
No, sir, I think
Child book score?
child book score is there.
Okay, anyway, go read up about functional liver reserve and how to calculate it. Okay.
Oh, okay, sir.
Are we within time or?
Yes, sir, of course. If any finishing questions you'd like to give, sir, for the benefit of the other PGs who are on this
Oh, there's a
platform.
whole lot on hepatoblastoma. I would like to talk about